Good afternoon, everybody, and welcome to Monday midday Instagram chat. Today's topic is how do I get pregnant with diminished ovarian reserve? I'm Dr. Michael Jacobs, the medical director of the Fertility and IVF Center in Miami. So the first question is, what is ovarian reserve and how does that affect my chances of getting pregnant? And the follow-up is, how do we deal with this to help people get pregnant in an expedient manner? And as most people have realized, from our previous talks, a woman is born with a certain number of eggs, and each month after one starts to menstruate in your early teenage years, you release one egg, but most of the eggs that are present in the ovary actually shrivel up and just disappear over time. You may ovulate 400 or 500 eggs between the ages of 13 and 45 and stuff, but most of the eggs of the million that you're born with, it's a constant depletion process. So ovarian reserve is just a term that's used to refer to the quantity and quality of the eggs that are remaining in the ovary at any given time. And in general, the predictors of ovarian reserve, the best one is age. The younger you are, the more ovarian reserve you're going to have. And if you look at a group of women at any given age, a higher percentage of those women are going to have good ovarian reserve when they're young, when they're in their 20s, let's say, or even early 30s. And then when you get into your late 30s and early 40s, you'll see more women with less ovarian reserve, which is kind of intuitive, and also a lot of variability in trying to predict is my ovarian reserve good or bad, whereas if you're 23, more likely it's fine. Whereas when you're 38, it may be okay or maybe not okay. So how do we determine ovarian reserve? One, we ask you how old you are. Older is not as good as younger. Then we look at some biologic markers of ovarian reserve. FSH and estradiol on the second and third or fourth day of the cycle, or hormone tests that have been used for many years. AMH levels, or anti-Müllerian hormone levels. AMH levels are used, a little more sensitive indicator. It can be at any given age, there's a lot of variation in AMH, but a good AMH level would be over 2. A range of 1.5 to 2 is considered reasonable. When it gets under 1, it's diminished ovarian reserve age. And some of it you have to correlate in relation to how old you are. If you're 43 and your AMH is 1, it's a low AMH, but it's not bad for 43. Whereas if you're 28 and your AMH is 1, that's concerning, because women who are younger should have a higher AMH level, reflective of more eggs in the ovary, more good quality eggs in the ovary. Third way is you can look by ultrasound on the early part of the cycle on day 2, 3, or 4, and measure what are called antral follicles. These are little tiny black lakes in the ovary that measure between 2 and 10 millimeters in size and diameter. And theoretically, each one of those follicles can contain an egg that, if given fertility drugs, can be promoted to develop in that cycle of treatment. So if you're how quickly does ovarian reserve diminish? It's a constant downhill trend, but this trend will kind of increase the slope of it after age 35, and certainly much more significantly after age 40. So many times we have couples that, when we're trying to figure out why they're not getting pregnant, we find the sperm's okay, they have regular periods, they have an ovulation predictor kit that says they ovulate, the x-ray shows the tubes to be open. So everything's relatively normal, other than their AMH might not be as good as they would like. Unfortunately, there's no way to put more eggs in the ovaries. There's nothing that we can do to sort of rejuvenate eggs at this point in time. You have the number of eggs that you have. We can do some things to try and optimize the quality of the eggs that are there, such as vitamin supplements with DHEA, 25 milligrams 3 times a day, CoQ10, 200 milligrams a day, L-arginine, 500 milligrams a day. Some people use royal jelly, which is a bee extract. And those are all helpful, but they're not curative, basically. So if you have a couple with diminished ovarian reserve, it's telling us that the oomph of the ovary, the ability of this ovary to produce good quality eggs, is less, and that should be a signal to get moving on what we're doing. You want to be more aggressive in getting pregnant when you have diminished ovarian reserve. So there are two basic ways we try and get the best eggs we can out of the ovary. And the first approach is to use ovulatory drugs. These are sometimes referred to as fertility drugs. And we do ovulation induction. And this can be done with oral medications such as clomiphene or letrozole. They can be done with injectable medications called gonadotropins. It's FSH or HMG, Gonal-F, Follistim, and Menopur. Or they can be done in what's called the mini-stim approach, which is using the oral medications for the first 5 days and then low doses of injectable medications. And most commonly, we would combine the use of ovulation induction with intrauterine insemination to maximize the potential of a pregnancy in a cycle. So if you have diminished ovarian reserve, the first message is now's the time to get pregnant. You don't want to wait. If you're single, now's the time to try and preserve eggs, because it's only going to get worse as time goes on, and we can't wind the clock backwards. The only thing we can do is freeze it where we are and get the best quality eggs for what we have. If you're actively trying to get pregnant, one approach is inseminations with a fertility drug or some combination of fertility drugs, and the other approach is in vitro fertilization. The big difference between those two is how many eggs we're trying to get and what we're doing with the eggs. When we're using fertility drugs and insemination, we're trying to get you to ovulate 2 or 3 eggs in a cycle instead of just one. This has theoretically some advantages, and hopefully one of them is going to be a good egg and fertilize and result in a normal embryo that develops. But we don't want to produce 5 and 10 eggs in the ovary because we don't want you to give birth to triplets or quadruplets, etc. If we're doing IVF, then we're trying to get more eggs. And ideally, we'd like to get 10 or 20 eggs in a cycle. But most people who have diminished ovarian reserve, because their ovary has diminished ovarian reserve, by definition, it's not going to be as responsive to fertility drugs. And sometimes you can overcome some mild ovarian reserve by using higher doses of medication, but often, particularly when we see AMH levels under 1 and low numbers of antral follicles, even with high doses of fertility drugs, we don't see 10 and 20 eggs being developed. So we try and get 5 or 10, sometimes we'll get 3 or 4, sometimes we'll get 7 or 8, and we use with IVF, we're not worried about high order multiple births because we can control the number of embryos that are put back in. So if we're inseminating you with ovulation induction, whatever number of eggs you potentially are developing could potentially ovulate and fertilize. But with IVF, we're purposely overstimulating the ovary so that we can get your ovaries to produce multiple eggs, preferably in that 10 range if we can. But if you have very poor ovarian reserve, it may only be 2 or 3. And we can remove those eggs from the ovary. In the middle of the cycle, the eggs are removed by transvaginal ultrasound guidance under sedation. So it's a painless procedure. We get the eggs and we fertilize those eggs with your partner's sperm. So the big advantage of IVF is we're getting multiple eggs, or we're trying to get multiple eggs to fertilize more than 1 egg in a cycle and to hopefully have a better chance of getting a normal embryo. There is a concept of what's called age-related aneuploidy. And aneuploidy is when you have a normal egg and a normal sperm. They get together, and as that embryo divides, it divides abnormally. So the genetics of the embryo is abnormal. It has the wrong number of chromosomes present. And when you have an embryo that has the wrong number of chromosomes, eventually it'll stop developing, or if it actually implants, it'll miscarry, and really it'll result in a bad baby like a Downs baby and something like that. So the advantage of IVF is that if you look at the the incidence of aneuploidy by age, in women that are 25, 30 years old, 70% of embryos are normal genetically. They're called euploid normal embryos. 30% are aneuploidy. If we look at women 35 and 36, you're going to see about 50-50. So you get a higher percentage of abnormal embryos and a lower percentage of normal embryos. If you look at somebody 42, about 80% of embryos are abnormal. That's a big difference than when you're 28 and 70% of them are normal. So if the same incidence of aneuploidy is occurring naturally, and 7 out of 10 times at age 40, let's say, you're making an abnormal embryo, in 10 ovulations, even if all those ovulations result in a fertilized egg developing, 70% of the time it's going to be a bad embryo. It's not going to continue to grow. In IVF, you're basically getting a batch of eggs, so you can kind of speed up the process, basically. You get a batch of eggs at one time and can fertilize those eggs and let the embryos develop. On the 5th and 6th day of embryo development, you can actually biopsy the cells on the outer surface of this embryo, and with pre-implantation genetic testing, you can test these embryos to see if they're aneuploid or euploid, and basically select out the best embryos to put back. So you're getting, by using the fertility drugs, you get multiple eggs. By removing those multiple eggs, we're getting a better chance of a higher efficiency, really, because we're getting more eggs to work with in a cycle, in the hope that one or more of them is going to result in a normal embryo developing and to put an embryo back. Women that are over 35 with less ovarian reserve, meaning a lower AMH level, will tend to have higher incidences of aneuploidy for age, and again, there it becomes important. The other advantages of IVF are the potential of batching embryos. If we know that you want more than one child and your ovarian reserve is already low, and then you get pregnant, well, now you're pregnant for 9 months, and then you take 6 months to recover from that before you're ready to go get pregnant again. And so now you may be 2 years out from when we're talking in the first place. And if you already have low ovarian reserve at 37, let's say, at 39, or if you're 39 at 41 or 42, it's going to be much worse and much more harder to get people pregnant. So one of the advantages of IVF is the ability to stockpile embryos that are normal and go, okay, I don't want to transfer any until I have 1 or 2 extra ones, so that in case I don't get pregnant, I have some extra embryos. But more importantly, even if I do get pregnant, I have an extra embryo or 2 in the freezer, so I have an opportunity 2 years from now to use those embryos and have a better chance of them working than if I wait 2 years and then created the embryos at that point. So there are a lot of advantages for different reasons. But the big take-home message from ovarian reserve is, you start out life with good ovarian reserve, and it will only get worse as you go on. For most people up until 30, usually maintain fairly good ovarian reserve. It's going to continue to go down. The rate of a decrease in ovarian reserve increases after age 35, 37. After 40, it's a big slippery slope. And to take advantage of trying to improve your chances of getting pregnant, if you have diminished ovarian reserve, we utilize both some vitamin supplementation, but more importantly, the use of ovulatory induction, the use of fertility drugs to try and get more eggs to ovulate and time that with inseminations, or the use of IVF so that we don't waste a lot of time. If you have diminished ovarian reserve, we don't want to waste 6 months treating you with something that's not likely to work very well versus something like in vitro fertilization, where we have a much better chance of getting it to work. And IVF success rates are going to depend somewhat on age, but also on ovarian reserve, and most importantly, on our ability to transfer a normal embryo. If we have a normal embryo to put back, one that's been tested genetically with pre-implantation genetic testing, that embryo, even if you have diminished ovarian reserve, should work very similarly to somebody putting the same normal embryo in who had good ovarian reserve. The equalizer is having a normal embryo to put back in the uterus. That gives us our best results. The concerns in people who have diminished ovarian reserve, they respond less well to fertility drugs. They have a higher incidence of aneuploid embryos, and as a result, we have less embryos to work with. So I hope this short introduction to ovarian reserve has been helpful. Please feel free to ask us questions, talk to your doctor, and if you have diminished ovarian reserve, it's a signal to be a little more proactive in your treatment, try and do things that are going to work better more quickly, and certainly to work within a framework of what's most appropriate for you and your partner. So have a good afternoon, stay safe today, and we'll see you next week.